University of Michigan. She did her residency and an internship at internal medicine at Lutheran General Hospital in Illinois. She's originally from, or had done some undergraduate in Poland. She's going to be speaking today on osteoporosis, some of the things in family medicine that are important to us regarding osteoporosis would be education on DEXA scans, when to get, when to repeat, treatment recommendations, and also when to discontinue treatment, at what age and what parameters we are looking at there. We start at 12:15 and we end this at about 10 minutes to 1, leaving time for corrections, or questions, sorry. So welcome, and we'll let you get started. Thanks for doing this.
Okay, thank you so much for the introduction. So quickly, some statistics about osteoporosis. We see a lot of patients, unfortunately, that are not treated despite having fracture in the past. So only about 15 to 20% of patients receive osteoporosis treatment despite having prior fracture, as compared to beta blockers after myocardial infarction. And the osteoporotic fractures have much higher burden on the total population. It's much higher than breast cancer, heart, and stroke. And it's quite common. So worldwide, about one patient has a fracture every 3 seconds, and about 1 in 3 women and 1 in 5 men will sustain fragility fractures in their lifetime. And according to the statistics, there will be marked increase in osteoporosis and osteoporosis fracture in the next couple of decades. So part of it might be the lack of treatment, might be, for example, with osteoporosis fracture, that many of them are asymptomatic, and maybe only 20% of patients will have pain or realize that this is because of the osteoporotic fracture. And there are quite serious consequences of hip fracture. About 20% of patients will die after hip fracture because of complications or pulmonary embolism. 30% will have permanent disability. 40% will lose independently. It can affect daily living and impair independent activity even in 80% of patients. And with fragility fracture, the key is primary and secondary prophylaxis. Primary prophylaxis, treat osteoporosis before clinical fracture is developed. And secondary prophylaxis is treat after first fracture. So how do we diagnose osteoporosis? We can make a diagnosis based on the DEXA score. If the T-score is less negative than -2.5, either in hip, spine, or in the wrist. We can diagnose also in patients who sustain fragility fracture, which is pelvis, spine, hip, or wrist. And according to new guidelines released by American Clinical Endocrinology Society, based on the FRAC score, if the risk of fracture is high, more than 20% any fracture and more than 3% in the hip, then those patients can be diagnosed with osteoporosis that would otherwise meet the criteria for osteopenia. And that's important is for the payments, and patients with osteopenia will not be approved usually for reclass or Denosumab by Medicare or commercial insurance. So who should be tested and treated for osteoporosis? According to the National Osteoporosis Foundation, we should screen all women at age more than 65 and age more than 50 if they have risk factors. But the new guidelines from the Endocrinology Society released this year suggest we should screen all women starting at age 50. Men usually are screened later, after age 70, and anyone after age 50 after fracture. And who should get treatment? all of the patients who had hip or the vertebral fractures, these are considered to be fragility fractures even without DEXA result. And any patients who meet DEXA criteria, those are WHO criteria, with T-score less negative than -2.5. And patients with osteopenia range, which is T-score between -2.5 and -1.0, but who have FRAC score more than 20% for major fracture and more than 3% for hip fracture. And we should always remember that osteoporosis is a chronic disease and the treatment would be indefinite even when we do drug holidays, and I'll talk about those later. And what medical workup should we do in patients newly diagnosed with osteoporosis? All patients should get vitamin D, creatinine, and calcium. And most patients should have TSH if not done in the last year. And it's controversial according to osteoporosis experts, which patients should have more evaluation, including screening for celiac disease, maybe patients who develop fragility fracture or osteoporosis at young age or have unexplained weight loss. And which patients should have screening for multiple myeloma, maybe men with at younger age with osteoporosis fracture. And I used to order routinely parathyroid hormone, but this might not be necessary in patients who has normal calcium level. And I would order 24 urine collection for calcium to rule out hypercalciuria, but maybe in patients who have a history of kidney stones or of osteoporosis at younger age. And during evaluation in clinic, we also screen all of the patients for risk factors. Most of the osteoporosis, about 2/3, is genetic, and FRAC score takes into consideration hip fracture, usually in mother. And when we screen in patients with excessive alcohol use, which is more than 2 drinks per day, and cigarette smoking, we suggest lifestyle modification. We check the calcium intake, as well as peak bone mass. Patients who had oophorectomy at younger age would not develop peak bone mass and would develop osteoporosis earlier, as well as patients can develop from apoptosis of the osteoblast. This is induced usually by chemotherapy or some medications, including glucocorticosteroids. Inflammation, higher risk in rheumatoid arthritis, ankylosing spondylitis. There are also multiple medications who can cause osteoporosis, early menopause onset, and so on. So regarding the calcium, for many, many years, we were worried that taking too much calcium can have detrimental effects on cardiovascular system and put patients at higher risk for early atherosclerosis. However, newer studies suggest that calcium less than 2,000 milligrams a day, it's beneficial, and patients should not exceed 2,500 per day. Dietary calcium is preferred, and for postmenopausal women and for men over age 70, total calcium, which is dietary plus supplement, should be around 1,200 milligrams. And vitamin D generally recommended 600 to 800 international units daily. The goal level is usually 25 to 60, and we shouldn't really aim for goal closer to 100 because it's not gonna benefit the bone health further. And we always counsel all of the patients how to move safely to avoid fractures and on exercise. Having lower extremity weakness, imbalance puts them at high risk for fracture. There is a nice brochure that you can get online from Canada, and patients can download it. It's called Too Fit to Fracture. It's a very good booklet recommending patients what kind of exercise they should do and what kind of exercise to avoid. So what is fragility fracture? It's a fracture that is sustained from minor trauma. For example, if it would be wrist or shoulder, hip fracture, it's a fall from standing height or less. And typical sites are spine, hip, wrist, humerus, and pelvis. And you can make a diagnosis if you have a patient with fracture, even without bone mineral density result. And I'll talk only briefly about bone remodeling because it's important when we classified agents used in osteoporosis. There are three major cells in the bones: osteoclasts, which resorb the bone, and this ends with osteoclast apoptosis, and medications that target osteoclasts are anti-resorptives. These include bisphosphonates, denosumab, estrogen, and raloxifene. And cells that synthesize organic matrix and build new bone are osteoblasts, and they are usually targeted by PTH analogs. And they have two fates. They differentiate into cell death, into osteocytes, or remain on surface and differentiate into bone lining cells. And the third type are osteoclasts, and they were neglected for a long time in bone mineral research, but with new medications, it turns out that they are quite important because they release sclerostin, and I'll talk about it later at the end of the presentation. So our first line for treatment osteoporosis are still oral bisphosphonates. Most commonly used is alendronate. And we use them first line in patients who were just diagnosed with osteoporosis, had no fragility fracture or maybe only one fragility fracture, and if they have no contraindications. Contraindications to oral bisphosphonates include esophageal disorders, for example, GERD, patients who had gastric bypass in the past, and also inability to stay upright after taking medication for 30 to 60 minutes. And also patients with chronic renal insufficiency. If the GFR is less than 30, we tend to use Denosumab, which is a safer option. So if patients, for example, don't tolerate oral bisphosphonates and creatinine is normal, then frequently you use first-line zoledronic acid. And with renal insufficiency, first line would be Denosumab. And anabolic agents can be used in first lines, usually in patients with multiple fractures, or if they have very low T-score, less negative than -3.5. So second line medications, if contraindication to oral bisphosphonate, if they have intolerance of bisphosphonates, for example, bone pain, very low T-score, multiple fractures, chronic renal insufficiency. And the mechanism of action is very important when we compare anti-resorptives because of increased risk of atypical fracture with prolonged use. And there is a big difference in the mechanism of action bisphosphonates compared to Denosumab, and I'll talk briefly about it. Bisphosphonates, after intake, they are built up in the bone, and then they are absorbed, digested by the osteoclasts, which makes them inactive. Denosumab, it's completely different. It's reversible. It inactivates osteoclasts only for 6 months, and then it's completely out of the system. And when we use bisphosphonates, it's added in the bone, and that might put patients at risk for atypical fractures. So we have 3 oral bisphosphonates: alendronate, bisedronate, ibandronate, and the IV zoledronic acid and the ibandronate. So those medications are still quite effective. They reduce new vertebral fracture by 50 to 60% and non-spine fractures by 30 to 5%. The number needed to treat after 3 years of taking it are 9 for vertebral and 90 for non-spine fractures. And I'll talk briefly about the clinical trial published at New England Journal of Medicine in 2018 in patients with osteopenia treated with zoledronic acid, because I think that's the reason why Endocrinology Society changed the criteria to screen women earlier and maybe treat women earlier with osteopenia range if they have a high FRAX score. In this trial, they treated 2,000 women with hip bone mineral density in the osteopenia range. And they used zoledronic acid every 18 months total 4 infusions, and it was compared to placebo. They used this regimen for 6 years. They noticed in patients with osteopenia, there were 35% fewer non-spine fractures, 55% fewer vertebral fracture, and 35% fewer hip fracture, and the number needed to treat was 15. And in this clinical trial, patients on placebo, they had total 190 fractures, and on zoledronic acid, 122, so it was quite significant. You can see here, it was much more effective, delayed the onset of the first fragility fracture compared to placebo, as well as it was more effective than placebo for non-vertebral fragility fracture, symptomatic fracture, and it did affect change in height, which means it prevented maybe those silent asymptomatic vertebral fractures. And the zoledronic acid we usually use in clinical practice a little bit differently. This was done for osteopenia, and infusion was done every 18 months. Usually when I treat patients with osteoporosis with zoledronic acid, I give them once a year infusion, and I limit it to 3 years, and there is data behind this. If we use the zoledronic acid for longer than 3 years, we usually don't see increased gain in bone mass. And I would suggest in patients who don't have any increase in bone density after 3 years of bisphosphonate, this is when you hit a plateau and the bone density doesn't improve further, then I would switch those patients to Denosumab. And another reason for limiting the treatment to 3 years is the increased risk of atypical fracture, mostly with bisphosphonate use. So the Denosumab, it's completely different than the bisphosphonates. It's purely human anti-wrinkle antibody. It will block differentiation of the osteoclast precursors to mature osteoclasts. So it's like bisphosphonate anti-resorptive, but it's fully reversible. And we're not sure why, but it does work much better than bisphosphonate if you have a patient who needs treatment for longer than 3 years, longer than 5 years, or maybe a patient who needs indefinite treatment. And some people postulate that the way it works more efficiently beyond the 3 years is the access inhaversion canal. Because of this blood flow, Denosumab can inactivate osteoclasts more effectively than bisphosphonate, which usually affect the osteoclasts only on the surface of the bone. And this is a nice trial showing the effectiveness of the Denosumab. You can see here that it does improve bone density in the from baseline after 10 years of treatment by 21.7%, and including improvement in the T-score of the wrist, as well as femoral neck. So most of those medications are not as effective in improving the bone density in the hip compared to spine for some reason. But there is a new problem that we discovered a few years ago. Patients on Denosumab cannot stop the treatment abruptly. If the treatment is stopped, we see increased bone loss, as well as increased risk of vertebral fracture in the first year after stopping. So if for any reason your patient cannot stay on the Denosumab before you stop, they should be transitioned either to alendronate, or you can give them 1 dose of zoledronic acid before they go on holiday. And a few words about PTH analog. One of them is Teriparatide, which is Forteo. It has been available since 2002. We limit the use to 2 years only because of osteosarcoma in rats, but we don't think there is increased risk in humans. It is much more effective than bisphosphonates overall, particularly in steroid-induced osteoporosis. Another medication approved in 2017 is Abaloparatide, which also stimulates more osteoblasts, but it can affect osteoclasts as well. And the study published in 2017 compared the Teriparatide to oral bisphosphonates, and you can see that it does significantly reduce clinical fracture, cerebral fragility fracture, and first, I think this one is pretty much the same. And this is data compared within the 24 months of using it, of the Teriparatide. Abaloparatide, it's slightly different. It doesn't need to be refrigerated, and it's used over a period of 18 months. And it does seem to be more effective than Teriparatide. So I'll talk about drug holidays. Who should be considered for drug holidays? American College of Physicians recommends stopping bisphosphonates after 5 years of treatment, but we can do it only in patients who are low risk for fracture. So we did not worry in 1995 when the bisphosphonates were approved about using them forever. In 2010, we had a warning from FDA about the duration of treatment. And after we stop bisphosphonates, even after 5 years, the half-life for the alendronate can be even 10 years. So with those medications, bisphosphonate, if we stop after 5 years of treatment and our patient T-score is not at goal, that suggests that we should switch to different agents, maybe after 2 to 3 years of bisphosphonate, if there is no significant improvement. And we try in osteoporosis to have goal-directed therapy, which means we have certain goals in mind before we can put patient on drug holiday. So the hips T-score should be above -2.5, and in spine either -2.0, or some experts recommend less negative than -1.5 before patient is considered for a holiday. And we should aim also for a patient to be fracture-free for 5 years. And how do we assess the response to therapy? Usually with DEXA, repeated every 1 to 2 recovers only every 2 years. We see if it's stable or increased, if it's declined, or if they have a fracture while on therapy. This usually suggests that we should change the treatment. So drug holidays, only patients with low risk for fracture, which means no prior fractures, or fracture-free for 5 years. T-score above -2.0, maybe age less than 65 and having no other comorbidities. So this is a simple diagram, and you can review it later about the duration, the treatment, and drug holidays. And what is high fracture risk? Age more than 70. After 5 years of treatment, you can still use the FRAC score, although sometimes the radiologist reading the DEXA will not read it. If the FRAC score is above threshold for if patient was never treated, you should continue treatment with whatever agent you choose. And also high fracture risk if patients had any major fracture before or after therapy, and patients particularly with vertebral fracture. Those patients are very high risk for refracture and maybe should never be on a drug holiday, or you can use anabolic agent as a holiday from bisphosphonate. Also, if patients are on new medications, prednisone, aromatase inhibitors, or leuprolide, they should not be considered on drug holiday till they are off those medications. And a few words about osteonecrosis of the jaw. I'm sure you have a lot of questions from patients regarding this. Osteonecrosis is the exposed bone in oral cavity despite treatment over 6 to 8 weeks. It's usually seen in patients with cancer who are also on chemotherapy, and usually they get IV bisphosphonates. There are some reports of Denosumab, but it's mostly with the zoledronic acid. We're not sure what triggers it. Infection is a universal finding, and counseling is usually having good oral hygiene. So most patients had IV bisphosphonate. Only 4% of those patients with osteoporosis had cancer. Majority of osteonecrosis of the jaw is triggered by tooth extraction. And sometimes we try to plan to have a scheduled extraction. For example, if they are on Denosumab at the end of the Denosumab, end of 6 months. If they are on oral bisphosphonate, we can hold bisphosphonate for 3 months before the extraction, but this is only in patients who have been on bisphosphonates for longer than 3 years. If it's less than 3 years, we don't change medications. And this is an example of the osteonecrosis with radiograph. And I'll talk briefly about atypical fractures. Those are associated with prolonged use of treatment, mostly bisphosphonates, if they've been on treatment longer than 5 years. And the atypical fracture is simple transverse or oblique fracture with cortical beaking, diffuse cortical thickening. It's usually no trauma, low-level trauma. Majority of patients will have prodromal pain, which is thigh pain, and those patients should be X-ray, and frequently they have collateral changes, and I'll show you X-rays. So you have to, for atypical fracture, you have to meet 4 out of 5 major criteria: minimal no trauma, fracture line originates at the lateral cortex, and it's transverse, and it's not or minimally comminuted, and complete fracture extends through both cortices. And typical, it's the beaking in the bone. I'll show you a radiograph of that. So the prevalence is quite low. It's 3 to 5 cases per 1,000 of hip fractures. Bisphosphonate use almost double the risk, and it's mostly in patients who have been on bisphosphonate longer than 5 years. There's a new study published at New England Journal of Medicine this summer. This is from Kaiser Permanente from California. They evaluated 1 million of women, 17% use bisphosphonate. And out of 200,000 of women, 277 had atypical fractures. And I'll quickly just go through this table. Major risks are increased age, having Asian ethnicity, use of bisphosphonate longer than 3 years, but it's even higher after 5 or 8 years of treatment. As well as patients who have shorter height. So this is another table, mostly in older patients, Asians out of proportion to other races, chronic bisphosphonates use mostly after 8 years of treatment, and the risk goes down rapidly after stopping bisphosphonate if this is oral. And this shows number of prevented fractures compared to patients with bisphosphonate use, atypical fractures. And you can see, particularly in Asian patients, marked increase in the atypical fractures compared to white Caucasian women. So in any patients on chronic bisphosphonates, look for prodromal thigh pain, and if patients would have pain outside of just doing X-rays of the femur, and typically we would add bilateral femur because those changes can be bilateral in 25 to 50% of patients, happens with minimal no trauma, and patients have local periosteal reaction, which is like a callus at fracture site. So patients worry about it, and we worry about it. But when we compare to 1,200 fractures, for 1,200 fractures prevented, you will have only 1 atypical fracture after 3 years of bisphosphonates. So because of the osteonecrosis of the jaw, because of decreased DEXA reimbursement, and because of risk of atypical fracture, it's all over the news. We actually see decreased use of bisphosphonates. in US, as well as increased fracture despite having very effective treatments. And these are radiographs of atypical subtrochanteric fracture. You can see it starts on the side. It's usually transverse, although further it can be oblique. And this is typical beaking, which you can see even before fracture occurs. So this is a progression. First, you see hairline fracture, which gets increased. You get callus formation before it progresses to complete fracture. And many orthopedic surgeons, if they see beaking and incomplete fracture, will use intrafemoral rod as prophylaxis. It's controversial how we treat it. Other than stopping bisphosphonates, there are only case reports about using teriparatide to help the fracture if there is delayed healing. And just a few words about Romosozumab. This is a new medication approved last year. It's done intramuscularly in the office every 1 month for 12 months. There is a black box warning, increased risk of cardiovascular events, and we usually prescribe patients who had MI or CVS in the last 12 months. So the Romosozumab, it's different than the PTH analogs, because it does affect bone remodeling in a different way. It does stimulate osteoblasts, but it also suppresses osteoclast formation. So it's a dual action anabolic agent. And the way it works, it does block sclerostin, and sclerostin is secreted by osteocytes, and it blocks osteoblast differentiation, and also this rankle expression, and this way increases osteoclast activity. So blocking sclerostin, we have increased efficacy of from the osteoblast and decreased activation of the osteoclasts. I'll just skip this. So it's a dual action agent, but it's different than regular anabolics. For Teriparatide, we do not use in patients who have prior radiation because of risk of osteosarcoma. Romosozumab can be used in patients with prior radiation from, for example, from breast cancer. However, it's not approved for men. It can be used in patients with low hip T-score or history of hip fracture, because the PTH analogs are not as effective in increasing bone density in the hip. It can also be used in patients with previous PTH treatment, and the PTH analogs might be preferred in patients with vertebral fracture, fracture healing, non-union, safer in patients with recent cardiovascular events. For patients' preference, if they prefer to do treatment at home, then PTH analogs would be preferred. Can be also used after Romosozumab. Abaloparatide, it's easier than the Forteo because it doesn't need refrigeration. And this is brief overview just to show you how effective those treatments are. So the Romosozumab, it does increase bone density much more effectively than Teriparatide and the alendronate. And it does increase the bone density in both lumbar spine and hip. And this is just a review of the switching Romosozumab to Denosumab. You can see here on this graph that the Romosozumab, it will improve the bone density within 1 year as much as Denosumab within 5 years. So now there is this new trend, it's called foundation effect, to use the anabolic agents, for example, Romosozumab as first line in patients, particularly with multiple fracture, and then use Denosumab for the rest of the treatment. So there might be increased cardiovascular risk with Romosozumab, but we are not sure. There are some studies suggesting that there is increased cardiovascular risk in patients with osteoporosis, so it might be underlying disease and not quite medication only. So again, anabolic compared to anti-resorptive, you have larger bone mineral density gains, 6% in hip after 1 year of Romosozumab, but the anti-resorptives, particularly alendronate, are easy to use, less expensive, the problem is only with duration of treatment. So if you have any questions, any difficult patients, and it's hard to manage patients with osteoporosis, or if you need to be referred, or if you have any questions, please feel free to always email me, and I'll get back to you as soon as I can.
Are there any questions? Anyone has any questions?
Hey, so this is Lily Brock. I'm the one of the faculty here. Just a question regarding when in the progression of treatment it's helpful for us as family docs to consult either endocrine or rheum. I tend to not prescribe an anabolic agent. If I get to that point, I'm generally, the patient is complex enough or their disease is severe enough that I want someone to think through that with me. Who are the patients that are helpful for you to see in the office?
Yeah, so that's a great question. I would suggest patients who had, for example, they present with multiple fractures. Let's say if they have multiple vertebral fracture, or if they have a history of both hip and spine fracture, because those patients we would consider for anabolic agents as first line. Other patients that I would refer is, for example, if you have a patient on bisphosphonate, if it's oral or IV, and if on follow-up DEXA scan, you either don't see improvement in the bone density, or if they have a new fracture despite treatment, then I would refer to either rheumatology or endocrinology, because in those cases we would either switch to Denosumab or maybe put patients on anabolic agent. So if it's severe osteoporosis, multiple fractures, not improving bone density on the DEXA, or if you're not sure if the patient should be on drug holiday or continue treatment, we would definitely reassess those patients. But also maybe patients with very low T-score, if patients has first bone density and the T-score is very low, if it's minus 3.5 or minus 4.0, then I think patients like this should not be put on bisphosphonate if it's oral or IV first line, because now we have those goals with therapy. And I know that this patient will not improve on bisphosphonates enough after 3 or 5 years on treatment to be put on holiday. So in those patients, I would either use anabolic agent first line or Denosumab, depending on the situation. So bad bone density, very low T-score, multiple fractures, or no improvement on DEXA, or new fracture on treatment, I would definitely refer. And any other questions?
Thank you very much for the presentation today. It was very informative. Will help us deciding treatment and evaluation in clinic. For those who want CME, please complete the evaluation that was sent out by Carrie. Return it to her, and if you have any suggestions for future talks that you'd like for on Tuesday, please let us know. And thanks very much, Dr. Sroski, for doing the presentation.